Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a very interesting case of a patient who attended with a left-sided grade 3 Keratosis obturans. So for anyone new to my channel, I will explain what Keratosis obturans is in a moment. I also do have a playlist on my YouTube channel as well, just dedicated to Keratosis obturans, so feel free to visit my YouTube channel if you're watching on a different format and select Keratosis obturans. So my colleague had seen this patient on 2 separate occasions, but was really struggling, and I don't blame, I can totally understand why my colleague was struggling with this. Now, at first it just looked like earwax, but as soon as I touched the surface of this plug of dead skin, I just knew it was Keratosis obturans. So what is Keratosis obturans? Now, Keratosis obturans is an accumulation of dead skin cells within the ear. Now, I know many of you watch my videos on a regular basis, so you're probably going to hear this for the millionth time, but for anyone new, our ear canal and the outermost layer of the eardrum, so the eardrum is actually made up of 3 layers. The outermost layer, the lateral layer facing us, is made up of the same skin that lines the inner 2/3 of the ear canal. It's this epidermis layer of skin made up of epithelial skin cells. Then the middle layer is made up of fibrous tissue, and then the innermost layer of the eardrum is made up of mucosal skin. So the mucosal skin is similar to the skin found in the inside of our nose and mouth. It's this kind of a secretory skin cell. So collectively, these 3 layers form the eardrum, and they are approximately in thickness collectively about 0.2 millimeters. So it's extremely thin. Now, as the skin dies in the ear and sheds, it moves sideways out of the ear, or at least it should, almost like a conveyor belt. Think about a snake when it's shedding its skin. Now, with a snake, the snake comes out of the dead skin. It's the same principle, but the other way around. The dead skin comes out of the ear. So it moves sideways, slowly but surely out of the ear at a rate of about 1.5 to 3 millimeters a month. And as it migrates outwards, these skin cells are interconnected, and as it's migrating and dying, they should separate and flake away and then eventually expel itself from out of the ear. So a Keratosis obturans is when this dead skin fails to migrate and it forms into a plug. So all this dead skin, as it's coming out, it just forms a plug, and this plug gets bigger and bigger and bigger. Now, this plug has got the ability to get so big that it actually starts to widen the bony part of the ear canal. Imagine how much pressure there must be in this skin plug to actually remodel the bony part of the ear canal. So it does it in 2 ways. It does it by the pressure effect. So think about a rubber ball inside, very deep, and you're getting bigger and bigger. The bone, and the bone that makes the ear canal, the temporal bone, is regarded as the second strongest bone in the body behind the femur. And also what happens is when this plug of dead skin gets bigger and bigger, it irritates a thin sheath called periosteum, which sits on the bone itself directly. And the periosteum is designed to supply all the blood and nutrients to the bone and all the oxygen that it needs to exist, really. So when this periosteum is irritated by the pressure of this dead skin plug, it activates osteoclasts that sit on the bony part of the ear canal on bone. So the specialized bone cells that sit on the surface of the bone. And what osteoclasts do, they begin to break down the bone, and so all the minerals, all the compounds that make bone, they get broken down and they kind of get recycled. They get sent away into the bloodstream to different parts of the body. But this, with regards to the ear, because this osteoclasts are initiated, there's obviously less bone matter. So what it does, it creates a natural expansion, widening of the ear canal. Because there's less bone, obviously the ear canal is going to get wider. And you get 4 different grades of Keratosis obturans. Now, the hallmark symptom of Keratosis obturans is ear pain, otalgia. So all 4 do have that. Grade 1 is grade 1 and 2 is mild pain. Grade 3 is moderate, and 4 is kind of severe pain. In grade 1, you can get a skin plug like this patient, but there's no may not be any noticeable widening of the bony part of the ear canal, so no noticeable expansion. A grade 2 is when there is some visible expansion of the bony part of the ear canal, and grade 3 is when there's moderate expansion. But importantly, with grade 3, there should be granulation tissue, so inflammatory cells that form at the osseo-cartilaginous junction, which is the point where the cartilage portion of the ear canal, the outer third, meets the inner 2/3 of the ear canal, which is made up of bone. And you're going to see that in this patient. You're going to see some granulation tissue soon. And a grade 4, I have come across one before. It's extreme. Yeah, it's almost like the patients with a grade 4 is like they've had ear surgery. So the plug of dead skin is so severe that, and it pushes up against the bone so much that the ear canal merges with the bone behind the ear, the mastoid bone. So we call that an automastoidectomy. Typically that needs surgery. Now, keratosis obturans, because the patient already is in pain prior to attending, it's not only complex to perform before that reason, but this plug is right up against, compressed against the canal wall. And because the region where the keratosis obturans is forming is widened, which means the plug is quite big. Laterally to that, as you can see here, the ear canal is very thin and narrow, and quite often you can also get edema, swelling, which causes more narrowing. So the difficulty is you're trying to remove a massive plug of dead skin that's far larger than the rest of the ear canal in size, and the patient's suffering from ear pain. And as an audiologist in the UK, I'm not able to use any local anaesthesia. There is some topical drops you can get over the counter, but they're not going to be suffice for this level of pain. Now, my colleague did try the best, and I would say if after a couple of attempts you can't do it, do refer onwards. Don't continue, because you're just going to make the situation worse. And that's exactly what my colleague did, and it was difficult, as you can see, guys. So now slowly but surely bring this out. So this white peripheral matrix is it's actually the germination layer of the skin. So the epidermis layer, without going into too much biology, it's made up of 5 layers, the epidermis layer, and that was the more basal layer. When I mean basal, the bit that's in contact with the ear canal. So you can see we've removed this keratosis obturans, we're looking into the ear, and you can see this canal widens. It's quite a significant widening. On the right, there's some granulation tissue. On the left, also, you're going to see there's some granulation tissue. You can't fully see the eardrum at the moment, but you are going to shortly. Like with a grade 3, this is what this patient's got. You can often get some bleeding. You're going to see that in a moment. And that's because as you remove the plug of skin or peel dead skin off the canal wall, you can rupture some of these granulation tissue. And the granulation tissue is a buildup of connective tissue. So whenever you see granulation tissue, you can just see it on the left about 8 o'clock. You know there's been some trauma. It's not only in the ear but to the body, and it's a build-up. It's the body's inflammatory response. You get a build-up of connective tissue, and they have their own blood supply, their own blood vessels, capillaries. So when you start peeling away the skin or removing the dead skin, you can rupture this. You get some what we call contact bleeding. You're going to see that in a moment. Now this patient has got a couple of ulcerations. So when you've got dead skin like this, it's decaying as well, and when dead skin decays, it releases proteolytic enzymes, so enzymes that can start to almost dissolve and eat away at flesh and skin. And so they have got a bit of an ulceration at the bottom of the ear canal. A bit later, you're going to see on the left, they have got some ingression of some keratin, so you've got to be careful of a canal cholesteatoma. So these are kind of so with dead skin, it can do a lot of things in the ear, not only form into keratosis obturans, but it can cause other skin conditions like canal cholesteatoma. So there's not always a direct link between the two, but dead skin in the ear is not good, especially dead skin that's not migrating and it's collecting and it's releasing these proteolytic enzymes. So I'm just trying to peel away this layer of skin here. Now the patient can hear absolutely fine now. They do actually wear a hearing aid, so with the hearing aid in, they were able to hear as they normally would. But I just want to remove all this dead skin. I don't know what's underneath. And there's, you can see there's an ulceration there, probably a bit of granulation tissue. So we didn't make contact with that. The skin was sitting on top of that. And as we peeled the skin away, you could probably see some of the blood ooze from the ulceration. You can see this thick layer of skin. Now, in my ear, this skin would naturally move sideways out of the ear and shed itself. Another thing with Keratosis obturans is, I described earlier, as the skin, when the skin's alive and it's lining the surface of the ear canal, all the individual skin cells, they're like fish scales, they're interconnected. And as the skin migrates, it should not only come away, but the individual skin cells should separate. But with Keratosis obturans, one of the causes is that this skin, it does migrate, but it migrates inwards, so sort of out of the ear, it goes to the middle. And also, these individual skin cells don't tend to separate. Now, watch this bit, guys. This is a bit, I do remember this part. You can't really, you just think there's a bit of skin, but it's a huge plug of skin going to come out at the moment in a minute. It's quite large for you. Like, where did that come from? Now, guys, I'm going to let you continue to watch this, and whilst you do, I'm going to update everyone. It's a bit of a longer video, so I've got 10 minutes on what's been going on in the UK in terms of ear care. I have been doing updates on various social media platforms, and I've been really, really busy on some professional networks. So I've made a stance earlier on in the week. One of our membership bodies were promoting, and still are at the moment, bad practice. They are not only accrediting courses that train complete people with no previous clinical or ear experience to perform earwax in just a couple of days, and I've got evidence of that. These people come to me afterwards trying to get trained, and we politely say that you're not suitable for the procedure. So they accredit these courses. So imagine having your ears cleaned professionally by someone who has no previous experience. They could be from all walks of life. I mean, we've had beauticians that we know have been trained, car sales people, marketing experts, people who've done very well in their professions, but no previous experience, apart from having ears of their own. They've got no previous ear experience or healthcare experience even. And in 2 days, they're learning all about all the different pathologies in the ear, how to take all the history, then to learn how to, there's some granulation tissue, guys, to the right, then to learn how to look in the ear, which is no mean feat. And then on top of that, learning how to remove earwax removal with all the instruments, it's just bonkers. And in fact, I use that word bonkers because I've been in a lot of discussions with very, very senior, prominent, and highly, highly respected, and some internationally renowned ENT consultants over the last couple of days. I've had loads of talks with them, exchanging emails. And one of them this morning emailed me back, said it's absolutely bonkers what's going on. That was the exact words. Another one felt very troubled about what's going on. Now, from my discussions with the ENT, they are equally as concerned about this as I am. It's because it's public safety. Now, let me express to you guys, ENT are not, there's no profiteering out of this for them. ENT in the UK don't have time to do earwax removal. It's not something they really do anymore. In fact, ENT are referring patients to me. I've got 3 ENT consultants who recommend patients to see me because they're so inundated with all their surgical work. If they're doing earwax removal all day, they don't have time. They literally do not have time. So ENT are not raising this issue because it somehow affects their business model. They're busy operating. They would rather not be doing earwax removal in that sense because they've got such a backlog of really complex surgical procedures to perform, elective surgeries as well, that there's no need for them. They're not profiteering, guys. So it's not the reason why they're on side here. But ENT UK, and I'm going to give a big shout out here to the British Academy of Audiology, the BAA. They're one of our voluntary bodies. Typically represent more NHS audiologists. I was previously in the NHS, but I think as a private hearing aid dispenser, well, I'm 100% sure. So I'm very likely now going to become a member of them. Out of all the membership bodies, there's 3. They are really taking a stance against this, and I've had support from their president, vice president, a number of emails and contacts from a lot of their members, and they are actively trying to lobby the parliamentary specialist group for health and social care on this matter, and it has been raised in the House of Parliament, but it's just from what I've been told by ENT and BAA, there's no willingness from the government to make a change in this, and it's exactly the same with Botox. One of the ENT I was speaking to yesterday, they were explaining that this is exactly the same situation about Botox. In the UK, anyone can do Botox. You've got the Royal College of Physicians, plastic surgeons, GPs, so not just the plastic surgeons, saying this is not good, guys. This is not good practice to the government. Has some regulation, but there's just no will, and they've always been told, yes, we're going to get around to it, yes, but nothing's happened. So I'm basically leading a revolution, I think. The amount of uproar and noise that I've made about this within our profession. I mean, I'm getting responses from around the world from specialists now. It's gone a bit crazy, actually. And I've done loads of polls with the public and also with members of this one particular membership group. So going back to that membership group, not only are they endorsing these courses, they're accrediting them, but they're also wanting to introduce members. So these people who are getting trained by these courses, they want to include them in some capacity within our own membership. So they're looking to introduce an oral care register. So I don't really understand. I need to learn more about it, really. And we've had some things about it, but it just doesn't make sense if they're including this, because the whole idea of an oral care register is to raise standards, to have a list of specialists who have had the appropriate training and have prerequisites, clinical skills and knowledge. But yet they want to include people who have been trained in 2 days or so with no previous experience. I don't understand I don't know what I do actually know what they're trying to achieve, but I won't say it out loud, not just yet. Remember, there's a lot of influencing factors in terms, and I know because I've once upon a time been part of this membership body. I witnessed it firsthand, what sometimes can happen, and believe you me, I spoke out at the time. So they're wanting to include these members, adopt them in some capacity within this membership body, which is designed for people like myself, and include them into register. And I'm having none of it, absolutely none of it. And this membership body claimed that they did a poll, and I'm still waiting for details of this poll. I can't remember. I'm not saying they didn't do it, but I can't find the results on the website. They've got all these other poll results, so they're publishing the poll results from all the other polls on the website. I've not, but let me explain what they've actually said. So 3/4 of members who have responded, and apparently there's 18,000 members. So, but obviously that doesn't mean all of them have replied. So 3/4 of respondents, and looking at other polls that's been done and issued on the website. Well, there's only one poll where they actually cite the number of respondents, which I think they should be doing for every poll, really. I think it was about 350 to 400. So 3/4 of those, so just say there's 400, I think it's slightly less, but just say, for ease of mathematics, out of that 400, so 3/4, so 300 respondents are in favour of this, which mean 100 are not. I've already got on my own LinkedIn profile, I don't want to disclose the numbers yet because the poll's being released tomorrow, but the numbers don't add up. I don't want to release the numbers at the moment, but yeah. So I want details of this poll. I want to see the wordings that I've used, what question was asked, because all these are relevant factors. Now, I'm not saying that my poll should stand up under complete scientific scrutiny, because there might be biases involved, but I have got a vast number of people who oppose this. So and that's opposing the pure existence of these practitioners, what's been called associate wax members. Forget about the inclusion of them within this oral care register, within our membership body, but they actually oppose for them to be trained in the first place. And I've got the numbers. So it's caused a massive stir within the field, and quite rightly. people want me to talk about it, and I want to talk about it, but I have said to everyone, it's not just me here. We all got to talk about, we've got to educate the public, because in the absence of any governmental regulation, we as a profession, and I would have thought our membership bodies would be, the beacon behind all this. We have got to stand up for this. We, in the absence of these regulations, we've got to self-regulate. We've got to protect the public. We've got to oppose this. We've got to stamp it out, literally. If all of our membership bodies were doing the right thing and not accrediting these courses and opposing it, publicly opposing it, these courses who offer such practices, they're not going to get any trainers. Well, they are going to probably get some people getting trained, but it's going to reduce the number significantly, because when they've got their certificate, it doesn't mean anything really, because they've got no accreditation. Now, at the moment, that my courses, I've got the accreditation of this membership body. I don't really want them to accredit my courses. It doesn't mean anything. It's pointless. So we can actually change this. So a lot of my colleagues are obviously supporting me and want me, because obviously the profile I've got, I'm quite fortunate. I can speak to a lot of people. I've got that platform, but I've stressed to the guys, we've all got to speak together, not just me, because if we all make our voices heard as one, that's where real changes happen. And I'm convinced we can do this. So guys, there's a poll on my YouTube channel, select community, and then vote on this poll. I'm asking you the question, would you be happy to be trained by someone with no previous ear experience or qualifications after just 2 days training? Take care, guys. Speak to you soon. Bye.